Nigeria, we hail thee, our own dear native land. Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians all and proud to serve our sovereign fatherland. Our flag shall be a symbol that truth and justice reign. In peace or battle honored, and this we count as gain. To hang on to our children a banner without stain. Oh God of all creation, grant this our one request. Help us to build a nation where no man is oppressed, and so with peace and plenty, Nigeria may be blessed.
Great institution, law and university, excellence and godliness is our esteemed watchword. Though tongues may differ, in brotherhood we stand in Christ. Great institution, law and university, on Christ's foundation built, that cannot be shaken. Others may falter, our conviction we hold so firm. Great institution,
The head of program, Medical Lab Science. You're welcome, sir. Please forgive me for that. The head of program, Physiotherapy. You're welcome. Also, I will be introducing the hospital management staff. Let me start from the Deputy Director of Clinical Services, in person of Dr. Oyewusi. You're welcome, sir. Also, the Director of Clinical Services, in person of Associate Prof. Olayemi, right, and the Chief Medical Director, Professor Adekoke. You're welcome, sir. Still, you join us during the course of the program. Because this is a surgical presentation, all other teaching cadre are present here. Starting from the head of department, person of Dr. Olayemi. You're welcome, sir.
But also practical to assist in The topic for consideration today is very apt, considering the emerging technological innovation being employed globally for better patient care. Lecturer is a seasoned laparoscopic surgeon with vast experience in this area of surgery. He has agreed to share with us this afternoon from his wealth of knowledge in this area. This program has two segments. First is the lecture series that we're going to have, but the second aspect will be a short seminar from our partner, the person from the Lean Edge Pharmaceutical Company. They are already in the auditorium. They will equally give us seminar. Then there will be question and answer afterwards. Please let us be attentive and prepare to engage intellectually as the bench. But before I go, I want to apologize for us starting a bit late. There was a program this morning that actually engaged all of us. The university visitor was around, president commissioned our new 300 bed capacity auditorium and the MLS building. All of them were present this morning. So that's why we are starting a bit late. Thank you very much. God bless you.
Thank you so much, the Dean, Faculty of Clinical Sciences, standing in for the Provost. Thank you so much, sir. Please permit me to introduce officers and personnel from the Department of Internal Medicine. I'm starting from the head of department, the person of Professor Alija. You're welcome, sir. Also in the department, we have Professor Ndububa. You're welcome, sir. Also in the department, we have Associate Professor Olayemi. And of course, we also have Dr. Mrs. Adeleke. I will take other faculty members as we progress during the course of the program. We move briefly to the comments by the CMD. I don't know if that has been dedicated. Not yet. Okay. Permit me to go to the department where we see the beginning and the ending of lives, fortunately. But we are the one that pilots everybody in this room to the world. The Department of Obstetrics and Gynecology. Yes, we are oil and gas, we are rich. Though the surgeons consider us two-finger doctors, we are satisfied being two-fingers doctors. We ascertain that you are not all better associated when you landed. Of course, we cannot take all credits. Do that along with our indefatigable pediatric team, who have always been there to ensure that we do not have better associated leaders in these various positions. Unfortunately, I think that some of our leaders missed their attendance at their birth. Hence the dividends we are seeing in society. But don't you think so? Alright, the Department of Obstetrics and Gynecology. My head of department is Dr. White Bakari. Please permit me to say our clinic runs today, and most of our patients are actively on the ground. Also in the department, we have Professor A.O. Mulaja, currently in the clinic also. In the department, we have Dr. Oti Obo. Then we have junior lecturers that include Dr. A.O. Afolabi, Dr. Nadoyi, and Dr. Adelichi in the department. In the Department of Community Medicine, always want to give ourselves some space. So I'm going to the Department of Community Medicine. From the HOD, in the person of Dr. Aremu, to Associate Professor Mrs. Akambi, to the Department of Pediatrics, the head of the department, the person of Dr. Agelebe, in abstention, and of course, our Director of Clinical Services, the person of Professor Olayemi, as earlier introduced, from the department. Also, we have Doctors Adeago and Dr. Tijani. Okay. Is there any preparation for comments now? Please, can we go to the citation of the presenter and facilitator of the faculty lecture for today? Personally, I'm intrigued, and I'm sure all residents are intrigued, because it's something we have been yearning for, something we have been clamoring for, because it seems nobody does open surgeries without much anymore. In Nigeria, we myself will do it a lot, but when our counterparts, we dare not say certain things outside. So personally, I'm excited about the faculty lecture today. So the citation of our facilitator, please technical unit.
It is with great pride and profound respect that we present distinguished ladies and gentlemen, esteemed colleagues and honored guests. It is with great pride and profound respect distinguished ladies and gentlemen, esteemed colleagues and honored guests. It is with great pride and profound respect that we present this citation in honor of Professor Olaomi Oluwole Olayemi, an exceptional clinician, scholar, and leader whose contribution to surgery, emergency medicine, and health systems development have left an indelible mark on Nigeria and the global medical community. Professor Olaomi began his academic journey at Obafemi Awolowo University, Ile-Ife, where he earned a Bachelor of Science in Health Sciences in 1985 and the Bachelor of Medicine and Bachelor of Surgery MBCHB in 1988. He further strengthened his leadership capacity with a Master of Business Administration MBA in 2017. He underwent rigorous postgraduate surgical training at the Obafemi Awolowo University Teaching Hospitals Complex from 1991 to 1999. Earning the fellowship of the West African College of Surgeons in 2000. His pursuit of excellence led to additional prestigious qualifications, including Fellow, International College of Surgeons, 2004, Fellow, American College of Surgeons, 2015, Fellow, National Postgraduate Medical College of Nigeria, 2017. Fellow, Faculty of Emergency Medicine, 2021. ATLS, Advanced Trauma Life Support Instructor Certification, 2020. His international exposure includes advanced training in trauma surgery, South Africa, 2005, gastrointestinal endoscopy, Egypt, 2006, and minimally invasive laparoscopic surgery, USA, 2007. Currently an associate professor of surgery, 2021 to present. Professor Olaomi is widely respected for his expertise in trauma surgery, laparoscopic surgery, and gastrointestinal endoscopy. He has held numerous high-level leadership roles, including Director of Clinical Services, Chairman Medical Advisory Committee, 2017 to 2019, and multiple appointments as Acting Chief Medical Director, 2017 to 2019, at the National Hospital, Abuja. A visionary in trauma and emergency care, Professor Olaomi played a pivotal role in the establishment and coordination of the National Trauma Center, Abuja, from 2014, significantly strengthening trauma systems and emergency response in Nigeria. On the global scale, he has contributed immensely to landmark international clinical trials as a principal investigator, including CRASH 1, corticosteroid randomization after significant head injury, early 2000s, a major international study evaluating the role of corticosteroids in traumatic brain injury. CRASH 2, clinical randomization of an antifibrinolytic in significant hemorrhage, 2005 to 2010. A groundbreaking trial demonstrating the life-saving effect of tranexamic acid in bleeding trauma patients. CRASH 3, clinical randomization of an antifibrinolytic in significant head injury, 2017, a global study establishing the benefit of tranexamic acid in traumatic brain injury. Alt-IT trial, 2013 to 2020, hemorrhage alleviation with tranexamic acid intestinal system. An international randomized trial investigating the use of tranexamic acid in gastrointestinal bleeding. These studies have significantly influenced global emergency and trauma care guidelines and have saved countless lives worldwide. Professor Olaomi's academic contributions are extensive, with numerous publications in reputable international journals and active mentorship of postgraduate trainees. His excellence has been recognized through several awards and recommendations, including Letter of Appreciation, National Hospital, Abuja, 2003. Special Recognition Award, National Hospital, Abuja, 2003. Letter of Recommendation for Excellence, Oyo State Hospitals Management Board, 2005. CRASH 2 Trial Recognition Awards, 2006 to 2007. Certification of Contribution, London School of Hygiene and Tropical Medicine, 2014 and 2018. Certification of Appreciation, World Blood Donor Day, 2018. Letter of Commendation for Outstanding Leadership, National Hospital, Abuja, May 2nd, 2019. Beyond clinical and academic excellence, Professor Olaomi has demonstrated unwavering commitment to community and national service. He has served on national medical teams, including the FCT Christian Pilgrimage Medical Team 2019 and the FIFA Under-17 World Cup Medical Subcommittee as president of the Association of Surgeons of Nigeria 2024 to present, and has contributed immensely to professional and faith-based organization. A devoted family man, Professor Olaomi is married and blessed with 2 children, exemplifying balance between professional excellence and strong personal values. Today, we celebrate not only a surgeon of exceptional skill, but a leader of vision, a mentor of many, and a servant of humanity. His life's work stands as a testament to dedication, excellence, and impactful service. Ladies and gentlemen, it is our great honor to invite upstage Professor Olaomi Oluwole Olayemi, a distinguished icon in surgery and a true champion of healthcare advancements.
And the College of Surgeons in his country recommended that it should be decertified by the Council of Medicine. And his papers were not published until 10 years after the first appendectomy. And today, it has become the preferred standard of management, surgical management in developed countries. So there are new procedures that come out every day, including thyroidectomy, pancreatectomy, colectomy, as opposed to the basic appendectomy and cholecystectomy that we do frequently. Nigeria and many African countries are yet to fully embrace a surgical approach, like in everything that we have. What do we need for laparoscopic surgery? There are hardwares. We need the laparoscopic tower, which consists of the screen, which our normal television can do. That screen was consulted by me. It was the screen I was using in my house until the volume had issues. Pictures are good, but the volume had issues. Instead of repairing it, I converted it to my laparoscopic screen. And with that, we have the light source, the insufflator, and the energy device. The energy devices are many, but frequent ones around are the diaphragm, which we have in this hospital, the harmonic scalpel, which use mechanical vibrations, and the ligature, which use pressure and radio frequency to work. We need carbon dioxide cylinder because we need space for us for optical vision. And in the beginning, we were not using carbon dioxide, we were using room here. But because of the risk of explosion with the energy device, we converted to carbon dioxide. Carbon dioxide is better because it's absorbed even by the tissues and the risk of explosion is down. But today, I can still tell you, in Africa, we use medical care. The hand instruments are delicate. Again, this becomes part of our problems. They are not manufactured here. So they are delicate. We have the scissors, miniature scissors. The same instrument you just use in Open has been miniaturized so that we can use them in laparoscopic surgery. The only difference is that the hook, which we don't use, which we use for diathermy, coagulation, and dissection. Likewise, there are new instruments, especially with the energy devices that helps with sealing and coagulation and reduce hemostasis during dissection. What stimulated my interest? First, my intestinal endoscopy activity with the Society of Gastroenterology and Hepatology in Nigeria, and then my association with the Society of Academic Surgeons. And like everything you see, seminars and training in Nigeria that translated to nothing. They were never domesticated. People come and train us, teach us, show us how to do laparoscopic surgery. We see it on the screen, telemedicine, particularly from Southwestern University of Dallas, and then after they go, we all go back to our open surgery. So this stimulated my interest and got me interested in getting certification, which I did in 2017 from the Harvard University Hospital in Waynes, Detroit. After I came back, I have to have the first patient. And my first patient, despite explanation, never understood what we were talking about. So this lady was my first patient for appendectomy. When I was asked to give this lecture, I went and fetched her out to give us a testimonial of what she did. So, can we have the video?
Stella Mensah, she was my first guinea pig of local laparoscopic appendectomy at the National Hospital. So we had to put ourselves together and assisted. She was the only person on that list that day. So we put her, explained to her, she signed double consent. We made her sign double consent in case we damaged her. Yes. So we prepared ourselves for the problem. And if you don't prepare, you think you're an expert. That is why you make mistakes. So we had everything in place. We had a double setup for her, and then we went in. This is her size. She's a bit on the bigger size. So that again gave us some issues. But I can tell you that our surgery was done within 35 minutes. And today, she's alive, she's happy for it. When she woke up, she asked, where is her scar? She was expecting the scar. She had read about it like most people. Most patients that are educated that come to you have an idea of what they expect. So after surgery, she had, and we used only 2 pots for her. So she only had the umbilical scar and one on the other side. And she was happy for it. And she's our friend today. So she advocates for us in the laparoscopic team. Next. Can we go back? Can we go back? Okay, yes, thank you. That's clear. No. Let me say that these 2 patients gave us consent. They know they will be featured in this lecture, so we got consent. And this is my sister-in-law. Her name is TK. Before this aside, she insisted she must be lepacious. And she has done everything, including 40 days fasting with water. And the weight refused to go down. She was actually obese because she's not stubborn. So we opted for laparoscopic sleeve gastrectomy. And it worked. So that is her new size today. She just turned 50 this month. She also sent her 50th birthday pictures for me to show, but that would take a long time. So she's doing well, we manage her well, we can see the effect of that with minimum scar. We only use 3 pots for her. So this is the next piece. This is a laparoscopic setup. This video is just for us to see the setup of our theater. And while we set up for laparoscopy, we also set up for possible open surgery. When we cancel our patients, we cancel them for also open surgery. They pay slightly more for laparoscopy, but they don't get change if we convert to open surgery. So this is just to show the setup. It's technical, but it's doable. Next slide. Okay, again, this is a setup. I put this video because of the challenges. So we can't see clearly here because we had problem with insufflation and bleeding. Because we used that time here, the harmonic scalpel was no more available as at the time we're doing this. So we had to convert to open surgery. Now, training next please. For us to become good in laparoscopic surgery or anything at all, we need training. So there are avenues for training within Nigeria. So we have this, our Society of Laparoscopic Surgery, Laparoscopic Surgery Society of Nigeria, which conducts yearly, we have camps, laparoscopic camp. So the advert here was that of 2018 in National Hospital. And our camps are hands-on because that's what makes it. It's not the workshop you walk into, have didactics, lectures, and go away and achieve nothing. We want you to have hands-on. So this is regular, we need, and with that, yes, you've seen us, you've been in theater, you need stimulators. So we need a skills lab where people can come in at their leisure time and practice. I still practice in my office, I still have my box where I practice suturing, I practice coagulation, I practice knot tying, and you will see why. So it's not expensive to have this. With your phone, you can have your camera there, you can design a box with the low things we have, low resources, and have a trainer which you can carry along. This is our workshop organized in October 2023 by the Wholesale Society, and you can find them online. They are a mixture of Africans and Americans. They work mainly in the East Africa, and they help with laparoscopic training. And they are courses they have online that you can actually do their courses online and train various modalities of laparoscopic surgery. But you will find very useful the laparoscopic appendectomy course and laparoscopic cholecystectomy course online, and they give you certification for this, and you can find a lot of resources there. So there are resources that we can use, and you can train yourself if you are committed to it. There are challenges, so this is just to show us the importance of our technicians. It's a teamwork, it's never a one-man's work. You need dedicated technicians who know what to do and how to manipulate your machines and how to keep them top-notch. And you need your scrub nurses who understand how to keep your instruments and your telescopes well, to clean them so that they don't get rotten as steel when you want to use them, and they don't cause leakage of your gas. So what are the challenges that we have encountered? So I put them in this section: the skill acquisition, operational cost, absence of industry, expanding frontiers in laparoscopic surgery, and there are other challenges that are peculiar to Nigerian and Africans. So for the skill acquisition, there is lack of or very little laparoscopic surgeons that many people can go over their shoulders. And even when they are present, the team is not present. The man that owns your camera, and most of the time, Professor Agbaku will tell you that the speed of the surgery is dictated by the assistant, not the surgeon. So if the assistant cannot understand your move, then you are stuck as a surgeon. So you need a cameraman whose punishment is to be stable. And if you miss the thing, you shout on the man. It's all fun of the surgeon. So it is difficult, and then it is not practiced in so many hospitals. Few teaching hospitals, federal medical centers, and private hospitals practice laparoscopic surgery. So for us to go train, we have few centers to look at. Then the operations are few in most cases. Even when they are done, they are few, and it takes a long time. The patients are not there, so the intervals are long. And learning laparoscopic require the use of stimulators. If we can get the electronic stimulators, the computer-aided stimulators, which are very expensive, they hasten your learning laparoscopic surgery. For skill acquisition, the second one, the investment in training indigenous medical personnel is poor for everything, not just if you look at it across board. The CMDs struggle with their training fund. Who do I give it to? It doesn't go around. Everybody needs training, particularly the doctors, but there are also other people in the establishment that needs training. So, and for you to go train, it's expensive to train in laparoscopic surgery. So, invest in training indigenous medical personnel and getting them to return to Nigeria after good training abroad is a societal problem in Africa and Nigeria. You know about the Japa syndrome in particular. And then procurement frustrates many people. The CMAC knows this very well. You order for something, that is if you know your specification. They bring something else for you and they want you to sign. And if you are difficult, you are labeled a difficult human being. That is if you know. But many people that order instruments and equipment don't even know what they are looking for. They just know this is a CT scan. What specifications of CT scan are you asking for? What do you expect your CT scan to do? What do you expect your machine to do? Can I have a laparoscopic tower that can also do endoscopy for me? Can do a GI endoscopy for me at the same time? So these are things that we need to know. So for procurement, poor procurement exercise in Nigeria, it's a problem. Then opportunity for telepresence and web-based education, they are limited. So operational costs. So the initial high costs, both direct and indirect, discourage our administrators from putting such money down. And then disposable instruments are expensive and may not be necessary for basic laparoscopic surgery. And then we have this poor patient's turnout. The absence of industry also affects us because the industries are not indigenous. So whatever you need, whatever the cost, they put extra cost on them to get them to you. And that makes after sales difficult. And most of these things are also through the middlemen who will put on their own cost on it. And there's no, the availability of service parts are a problem. The castors, I was using castors GI scope. Castors has discontinued that line. And when my scope had problems, and I got to them, they told me, don't bother repairing this scope, just go and buy another one. A new scope costs nothing less than 100 million with one gastroscope and one colonoscope. I got a quotation recently that says if I can get a striker that somebody sends for 98 million, I'm waiting when my salary will meet up to that. So they are again fast model change, making equipment obsolete and unserviceable. Once they change their model to new one, they tell you we don't have parts for this again, you must get another one. But how do we overcome this thing? Placement. But they don't accept placement for us. When you go abroad, you see people, you see so many instruments, you see the vendors, not just the vendors, the company rep are there. And those equipment are on placement. They don't buy equipment. They place them, they use them, they have the sharing formula. When you make a new model, you pack your old one and then bring in the new one. So they don't have that problems that we have. But let me tell you where those obsolete changed equipment heads, they heads with us. They bring them here as new one. Expanding frontiers in laparoscopic surgery. So the major frontier so far is the robotic assisted laparoscopic surgery. And robotics is the fastest growing frontier. It offers enhanced precision, dexterity, and visualization. Systems like the Da Vinci platform have already reshaped practice and ongoing innovation, including smaller, more flexible robotic hand, improved haptic feedback, and greater accessibility and cost effectiveness. You need to be on Da Vinci for you to appreciate what I'm talking about. I have been on Da Vinci, so I know. It looks as if you are moving this in surgery. I can see right what I'm doing. It's clean, clear. At times you can see below your organs if it's that transparent. And the instruments are very tiny and precision is very, very good. So, and this has helped with oncology, complex oncology procedures and abdominal surgeries. So, we need to move to get to there. We have not even gotten there. Then artificial intelligence and machine learning integration. AI is emerging as a transformative force by providing real-time intraoperative guidance, predicting complications and optimizing surgical planning, enhancing robotic autonomy through machine learning, and enabling personalized surgical strategies. So these two aims to improve precision, reduce operative time, and enhance outcomes. Also the advanced imaging and visualization, like just you have 4Ds, 3Ds, you have the augmented reality that will shows the overlying vessels, tumors, and anatomy. You have fluorescence imaging that shows you perfusion and lymph node marking. And these strategies significantly improve intraoperative decision making and safety. While we're still trying to go through the walls, people have already started going to the natural orifice. So there is no scar surgery. And people now going through the mouth, pass through the stomach, perforate the stomach, and go into the peritoneal cavity and do your surgery. And it's called natural orifice transluminal endoscopic surgery notes. And then we have the single incision laparoscopic surgery seals. This is just the same thing. Just through the umbilicus, you have a device that has 3-4 holes, and you put all your ports and your operating instrument there. When you finish, you just switch off the umbilicus back. So the aim is to reduce trauma, scarring, and recovery time while maintaining surgical effectiveness. So the next generation surgical instruments and materials are being developed. It includes give us more ergonomy, flexibility, miniaturized equipment. The energy devices have now been improved so that it's only what you want between the jaws of the handpiece that you get involved. You don't have scattering and scanning all around, and smoke is reduced. The smart instrument capable of sensing tissue properties, and whatever you push, what's that energy that for that particular tissue is discharged, that's all. So these tools expand the range of procedures that can be performed laparoscopically. Then telemedicine and remote surgery. For laparoscopic collaboration are becoming more visible due to high resolution video systems, low latency communications technologies, remote monitoring, mentoring, and training platforms. And this advanced supports global surgical equity and training. So for our other challenges, which are peculiar to us, frequent electricity disruption. So you need extra backup for your machine so that when during changeovers, you have UPS that can take this. Then frequent transfer of hospital staff within the institution. I had this problem in National Hospital. After training my endoscopy staff, and I can leave my scope with them, can do other things while they were trying to recycle the scope. You just come one day, they have been transferred to labor ward. And lo and behold, we've had occasions where gastroscope used was dumped in the water and they went to. So when we came in the morning, it was actually properly well soaked. It was like you soak mama. And that was the end of that scope. So lack of dedicated theater suits, because again, you may need to build your laparoscopic system, put your monitor so that apart from one system, your assistants, your nurse can have their own screen where they see what you're doing, and that makes life easier. So lack of patient willingness to be operated by indigenous surgeons for appropriate surgical conditions instead of traveling overseas. Many of our surgeons or our patients, particularly the rich ones, wants to go abroad. The only why they sought you is for diagnosis and for you to send them to the hospital you know abroad so that they know where they are going. Many people, they have lost confidence in the system, and that is a big problem for us. What are the prospects for Bowen University Teaching Hospital, Ogbomoso? Well, laparoscopic surgery in Nigeria is transitioning from a niche to an essential service with strong prospect for growth and boots. So if you please go back, this is available in Boot Theatre. This was the first day I entered the theatre. This was the first thing that struck me about this place. So I saw this and I saw the cylinder by the side and I looked at the system. It looks obsolete, but I'm sure it's likely to be working. Yesterday when I was operating in the night, I looked more and I find a 70 degrees telescope inside the container right by the side. I looked through and I saw it shining. So I think this is being used. And when I looked further, I found this business like, yeah, I found that there's an established foundation here. And I saw this presentation by Awotunde and Ogulaja. Preliminary report of experience with gynecological laparoscopic in Ogbomoso, published in the Gynecological Surgery in 2016. And that is part of their conclusions or findings. Over 28% of gynecological surgeries were performed laparoscopically. Procedure done were ectopic pregnancy, ovarian cystectomy, and diagnostic procedures. So we already have a footing in both. Again, for prospects, it's clinical usage. So technique is effective in specialized procedures like gynecological laparoscopy for infertility, in general surgery for appendectomy, bariatric surgery, and bowel surgeries. In thoracic surgery, video-assisted thoracoscopy, and in neurosurgery for pituitary tumors. So patient demands and benefits. It leads to significant shorter hospital stay and quicker returns to daily activities compared to open surgery. And then this will lead to increased patient demand, because if you don't have much pain, you are back at work. Many patients, when they tell them word of mouth marketing, patients will come, more patients will ask for it. It will increase our bed utilization rate, and it will increase the hospital generated internal revenue. And that will mean more money, we can buy us more equipment, and we can do more. Next slide. So if we introduce it, that was assuming that it was not there, or we revamp what is there now, it will provide an essential training opportunity for local young surgeons and interested seniors, theatre staff, and technical staff. And this expanding these training opportunities to the neighboring hospitals and teaching hospitals around will make Booth a surgical hub with increasing revenue generation and collaboration with all other hospitals. So what are the things that we need to locally look at? As a matter of urgency, compare the little ones we have around. The key challenges will be the cost of infrastructure. So with what we have, we can see what is working and what is not working, and what we can add to it, so that everybody can have access and it can work. Then the power system is relatively okay during the working hours, but it will need a UPS, big UPS, so that during the changeover of generator, the machine will not go home. Equipment maintenance, it's important. So whatever we do, we need to factor maintenance into it. The maintenance is mainly training people that will handle this equipment so that their shelf life will be long. And this requires sustained investment and specialized training to ensure consistent and high quality patient care. This is my family. We are blessed and we are displayed. That's my mom and our grandchildren. She passed away a few days ago. So, can I answer questions?
Thank you, Prof. Sir. Can I humbly request that you rest for some minutes? Please, our protocol team, please get in some. Thank you so much. Once again, can we put our hands together to our facilitator? Thank you so much, Prof. Sir. During the course of the guest lectures presentation, we had a few of our consultants working to start from surgery since the presenter is from the Department of Surgery. Please join me to welcome Professor S.U. Yes. Join me to welcome the head of Department of Family Medicine, who also doubles as the head of Accident and Emergency, Professor Amole. You're welcome, sir. Also during the course of the lecture, Professor Drodola also worked in. You're welcome, sir. Also during the course of the lecture, we have Professor Ogbomoso. You're welcome, sir. From the Oil and Gas Department. Yes. Apologies to the surgeons. Okay, also we have Associate Professor Adebuki. She also, you're welcome, ma'am. Then we have Head of Department Community Medicine, Dr. Aremo. You're welcome, sir. From the department of those that ensure that we're not better associated, we have Dr. Onibide. You're welcome, sir. Very welcome, sir. Also from the Blessed Oil and Gas Department, we have one of our consultants, Dr. Bubu. You're welcome, sir. Okay. While I was introducing the faculty members, I deliberately reserved the backup of our local hospital here intentionally because most of them were not on seat at the time. So permit me to run through the Department of Family Medicine. The head of the department once again is Professor Amole. You're welcome, sir. Also we have Professor Olaomi in the same department. We have Dr. Oluwole in the same department. Then we have Professor Drodola. We have Associate Professor Adeshino. We have Associate Professor Adegoke. We have Dr. Okwade. We have Dr. Oyewusi. We have Dr. Okechiaya. We have Dr. Sado. You're welcome, sir. We have Dr. Akiyemi. Forgive me. Before Dr. Akiyemi, we have Dr. Dire. You're welcome, ma'am. Then we have Dr. Adeoku, and then we have Dr. Tiso, and we have Dr. Dewole. Okay. Also, all the way from Igbo, the Department of Anatomy, we have Dr. Awolola. I'm very much recognized, sir. Thank you for coming, sir. All right, now we welcome questions. Welcome questions from faculty, lecture, speaker. Please welcome questions. Let's start from the from the medical students. Do we have two or one? Okay, we have one. Any other person? Two. Okay, we have three. I will not go beyond three. Let me start from the professors. And if they ask questions, you cannot ask questions. The residents in the house. Okay. Please, I need somebody to move this mic around. Question 1, 2, and 3, so that we have this quickly before we go to the doctors.
Good afternoon, everyone. All protocols being observed. Thank you very much, sir, for your lecture. I learned a lot about it. So I wanted to ask a question in regards to the prospect of the laparoscopic surgeries in Ogbomoso. Considering the general populace here, the economic status of the general populace here, and this surgery, obviously the equipment for it are going to be quite expensive. We really want to go full on it. How do we intend to, get people who can actually, at least for a start, afford the prices surgery so that we can generate revenue to get more equipment, sir.
Thank you for the question. Second question from the back. Let's make it snappy. Let's make it snappy. Let's make it snappy.
Good afternoon, sir. Thank you very much for your lecture today. I have a question regarding the budgets and scaling laparoscopy in Ogbomoso. You are given a limited budget to scale laparoscopic services at home. Would you prioritize equipment acquisition, surgery training, or maintenance systems, and why?
Sorry, the question again.
With a limited budget,
Okay.
to upscale laparoscopic services here at home, would you need to prioritize equipment acquisition, surgery training, maintenance of the systems?
Thank you so much. Question 3.
All protocol duly observed. Thank you, sir, for your lecture. My question is a bit specific and it regards to the scarlet surgery. Mentioned notes and seals. So about the notes, I wanted to ask, you said they will go through the natural orifice of the mouth to perforate the stomach. So how does that work to repair the stomach? Maybe that's I'm just curious. Then the second one, you talked about the single incision laparoscopic. If there's an incision, how do we avoid the scar? Where does the incision go for the other one? Those are my questions.
All right, thank you. Do we have other questions from the house? General house, the doctors, consultants, questions, please. Thankfully, the Director of Clinical Services is here in person, so I'm quite happy that she's here in person because we've been agitating for this, and I'm glad it's coming at a time like this. Thank God our Director of Clinical Services. Any questions from the doctors? Oh.
Thank you very much, everybody. I'm happy because Olaomi has good God. He didn't just talk about laparoscopy, minimal accessory, and endoscopy. About Dr. Moka is here. We were trained together by Prof. And then he has been the president of SOGI for many years. And before he came, in fact, when he was coming, I was praying that he should come. I was sure that we would activate the endoscopy here. When I was much younger, we used to have our society meetings, and we invited people from outside to come and show us video. We never had anything. We paid them to come and show video and go. But luckily over the years, with the assistance of the ones that trained us and the ones we trained, we now have endoscopy, laparoscopy all over the country with those going from outside assistants. Unfortunately, in boots, but we need to know whether someone has 50%, gastric ulcer, we have to refer, and it's beginning to be painful. And apart from limiting our service, all we can offer, and not getting us actualize what we want to do to patients, we need to show the students that are trained here that this exists in Nigeria. And some of them will not work in Nigeria, they work outside. It will be an invitation for them. They will have to feel, they have inferiority complex when they go out with their colleagues when they finish training. So what I'm emphasizing, now that Olaomi is here, I'm not having to escape this not here, and I thought the VC would be here. It's a very big investment. It costs money. But like I asked him, I would like to answer that because when we started living, when Lagos was charging 10,000 naira, if you were charging 500 naira for endoscopy, and it really happened, I remember yes. When other parts of Nigeria were charging up to say 10 naira, if you were charging 1 naira, easier. So we're able to train many people, and we can do that here. We have things that we can prepare here. If you encourage us, so we make better diagnosis. The students are exposed, the residents are exposed. So that's what I'm making a play for that. Some of the mistakes are here, they're terrible. We don't only need to fight. Now that nobody is allowing me here, we get information. And that somebody comes from the lorry, what do you say? We can all put hands together and get those again. We're glad that have done getting that person to get those back. That's what the player want to make. Thank you very much.
Thank you, sir. Any other question? Okay, in the absence, okay.
Thank you for the opportunity. Thank you so much, sir, for the very stimulating lecture. And since everybody has been turning to look at the hospital management, I feel that maybe I should just say something at this time. I want to emphasize that the hospital management is predisposed to getting this thing to work again. We actually applied for a grant sometime, I think some weeks back, 1 or 2 months ago. And well, even though it didn't come true, we'll apply again. And I want to plead with you, the elders, I mean, for the expertise in the laparoscopic surgery, to please help to build this up. If you have proposals as to how to make the tower and every other thing that we need to get it done, to get it to work, we are open to it, sir. Thank you so much, sir. Thank you.
Thank you, ma'am. Okay. In the absence of any other question, Prof.
Thank you for your questions. The first one is prospect of affordability in Ogbomoso. What we can do is what he has told you, what Ife did. We acquired the equipment and we brought the costs down. So we have more patients, and there is a policy you can't treat patients for peptic ulcer right from the GOPD. It's an hospital policy. If you suspect peptic ulcer disease, the patients go, the candidate patient goes for endoscopy. So the volume was increased. So in a day, you're using your scope for 30 people. It's different from in a day you're using your scope for 1 person. I hope you understand. That reduces your cost. It's like the laboratory. The laboratory people pull the samples together before they run it, even though they are running on automatic machine. So you make more money than when you are running a single one. So it's volume driven. Profit is volume driven, not just individual. That will help. Then in the setup, initial setup, we don't depend on disposable equipment. They are reusable. So we use reusable, and you can easily sterilize in pneumonia, in Paracel, and then that's what we use. They don't go to the autoclaving machine because they are rubber based. So you get that, and you can do 3, 4, 5 patients in a day for the same setup, and you make your money. Even if you don't have loop for appendectomy, a single suture, just think of an appendectomy that you are using only 1 suture. It's only 1 suture you are using. So even if you ask patients to buy, to put the money for material inside the fee, as we get it now, the difference should not be much for them. And that will recycle what we have. Even in ovarian cystectomy, you don't use more suture. So that is the way to start up. And these same patients go outside to tell the other populace that they don't have scar. And they left the hospital worse the second day. And they can eat the same day of the surgery. So this will help to bring the revenue to the hospital and reduce, at least offset the initial budget. So it's talking about the priority of equipment, of when we want to upscale, whether we want to focus on equipment, training, or maintenance. If we want to prioritize what you're going to have. Which was the priority? If I train you and you don't have anything to work with, will you stay? So if I'm going to train, if I'm a CMD and I'm going to train people, I need the equipment to be on ground. That would be my first year priority. So I will prioritize over years. I'm not going to do it at a single day. I'll first of all get the equipment down here. And let me be honest with you, there are so many ways of getting the equipment. The problem we have is that we don't look. There are people in this town that can afford to buy you this coat without thinking. Have we gone to our community and asked the senator or the House of Rep man that represents this place to make that a community project? So they have a lot of money, but nobody is engaging them. So if you engage people, there are entrepreneurs, there are philanthropists around here that can buy this, and we can name that theater suit after them. They will come and open it. It will be a fun fair. It will be nice for them, and they are happy. They are looking for the next boat, but you have what you want. So this is how you can do that. She's talked about grants, asking even the companies that are producing can be approached, because they have some, in quotes, out of technology, they are not new, that they are looking for where to dispose them. We have Ogbomoso people who goes to hospital abroad, where they take, well, what do you call them? When they change, they are not bad. They change the set of equipment and instrument they are using, and they're looking for people on charity to give it to. Nigerians go there, they pick them that is for charity, and they sell to us. You can apply to those people. You just need to talk to people where the charity things. You can talk to Kanti in London, that this is who you are. Collaborations. This is a Baptist institution. What happened to other Baptist institutions abroad? What is our association with them? You don't need to, everything does not need to be to go through the convention. We can have direct access. There were people here before that established this institution. Some of them are still alive. We can approach them, and they know what to do to make things happen in this institution. So these are ways you can get equipment and get. And when you get the equipment, then it's easier for the person you train to come back and practice. And when you are training the person that will use the equipment, you must prioritize the person that will maintain the equipment. The nurses and the biomedical engineers, they must be part of this. I hope you understand. So there are ways to do it. Then we talk about loads. It's easy. You perforate the stomach. You close the stomach on your way out. I hope you know we can use clips. It's all technology. The same way you perforate, when you are coming out, you get a clip and you clip where you go in. Okay? That's what is done. The scanners, which you can use with the thyroid going through your mouth, and then you get the thyroid and you get it done. You access. The easiest careless surgery that we do is breast lump that we remove from the areola. Many of you have seen it done. We target the areola area, which is black, and we open it a bit, get to the lump, remove it, and close the areola. In 3 months' time, the person does not know that, except he's one. In fact, some of them come to us and want to see where was our incision. They are the ones showing us that, because we can't identify our incision. And when you do the seal, it's the umbilicus. Below the umbilicus, it's open. There's a device with 3-4 ports. You put it in that place. When you finish your surgery, you close it subcute. And the place is black for some of us. In fact, some of the people we do for, they already have an umbilical area. So we just use that their area, go through this, and when we are coming out, we repair their area. They are happier. 2 surgeries in 1. So I think those are the questions that I have. Thank you.
Thank you so much, sir. Permit me to invite for the award presentation. Please, the award. Thank you, ma'am. Please, with a standing ovation, I want to invite Professor S. Eyeso. Please come, sir. Also,
So Olaomi, Olayemi, has come to us as a general surgeon and is a professor of general surgery. And we're glad to have him here. And we also we have also started the residency training in full orthopedics. We have institutionalize it. And even if I'm not here today, I believe that all the training programs for the orthopedics will go on in that, definitely programmed. That's what we want, and these are the things that will help us consolidate on them. I hope that by next time I do the accreditation, we'll get a part 2 for general surgery and possibly partial for orthopedics. That's what we're driving at. So please come here for residency program. That's my next picture. When you finish, come here. Now, I've talked to the CMAC and the CMD. Those buildings that the girls are getting, a lot of leave, all these 3 or 4 buildings, are going to be kept for residents only. All those, when you go to a 130-bedded hospital, hostel, those buildings you need will not be given to any other person. Only residents. They will refurbish them and furnish them. So come here and join us. You have light 24/7. If you go to any other place in Lagos, you pay to your people and ask what's her name? Yes, ask her. She will tell you how much she's paying when she's staying in Lagos. Almost 3 or 4 million. We'll give you for free. Yeah? And inside, light 24/7. Yeah? And we'll teach you, you learn a lot. So why I'm staying here, I want to institutionalize residency. By the time I'm going, you should have 1 or 2 consultants in the making. Okay? So my Prof, I'm honored to present this to you from Owen University, College of Health Sciences, Faculty of Clinical Sciences. Appreciation Award presented to Professor Olaomi, Oluwole, Olayemi, in recognition of your outstanding contribution as the guest speaker at the 9th faculty lecture organized by the Faculty of Clinical Sciences on this 28th day of April 2026. Thank you very much. Family medicine, surgery, please stand up. Pediatrics. Pediatrics, have you? Family medicine. So we have them now. Please, when you finish, you finally get students. Come back here for your residency program. I'm begging you. Thank you. Starting this residency program. Any teaching hospital that is starting must go through the same process. This is the stage we're in now. To institutionalize the residency training. By the time we can do that in the next 10 years, we won't need associate lecturers anymore. By the time you're having consultants in all areas, they have free. You do consultants here. You don't want to do. It's going to be the job is part 1 next time.
All professors, please join for the picture session. Professor Oluwole, Professor Oluwole, Professor Oluwole, Professor Oluwole.
Oh my God, what?
Please, other consultants. Congratulations, sir. We'll get here someday in Jesus' name. Or you're not looking at them and wishing, how much I wish they are there. And you've seen enough in this life. Please permit me to also introduce the Director of Nursing Services, Bowen University Teaching Hospital, in person of Matron Alagbe. Also, I must acknowledge the presence of the head of human resources, in person of Mr. Adeboye. You're welcome, sir. All right, let's pay attention to this announcement. Come the 4th of June 2026, at the new lecture theatre in Igbo campus, we have one of our eminent professors having his inaugural lecture in person of Professor Amole. So we congratulate in advance, sir. Wish you a successful outing. To be a blessed day in Jesus' name. Alright, to our pharmacy representatives. From Lean Edge Pharmaceuticals, we have Mr. John Ogbomoso and Mr. Tobiloba Nayabanjo. Please come for your presentation, sirs.
My name is John from Lean Edge Pharmaceuticals. Good afternoon, professors in the house, consultants, directors, and the resident doctors, senior resident doctors, everybody else. Let me just say all protocols duly observed. I want to, first of all, appreciate the organizing committee for this wonderful opportunity to showcase some of our products here today. Thank you very much for the opportunity. And once again, I want to sincerely appreciate Prof for that wonderful presentation. On a lighter note, I want to say that people like you are a testament to the fact that OAU is actually and truly over our university. Thank you very much, sir. Thank you very much. Please, I want to say, this is going to be our presentation flow. First of all, I want to introduce our zero name, which is our very benefit. So, majorly, this is going to be our presentation flow. And I will start by talking about the impact of the antimicrobial resistance in our society now. According to the World Health Organization, globally, antimicrobial resistance has
said to cause over 700,000 deaths annually. As a matter of fact, some take the number to about 1.5 million deaths globally. And they went further to assert that if proper care is not taken, between now and 2050, we are going to have up to about 10 million deaths annually. It's a very great concern that we have to take into consideration. And if you look at this critically, it's not all about the fact that patients that we prescribe these antibiotics to are not adhering to instructions on how to use them. It's not that you have them to take it DD or you have them to take it TDS and they are not adhering to it. But there are other factors that contribute to this, which can be likened to the fact that most companies, during the course of their production, they do not adhere strictly to the mandatory percentage of API that they are meant to take into consideration. In the context of Nigeria, the permissible percentage of API that is meant to be on one of these products are between 90 to 120%. But because of the cost of operation and the volatility of our economy, most companies tend to go for the lower limit, let's say about 90%, 95%. And when they do this, going to the fact that we have harsh weather conditions here and some other unforeseen circumstances, by the time they finish with the 90 to 95% API percentage that they've chosen, over time, by the time this drug will get to the end user, the percentage will have gotten lower than the expected API percentage. And part of this is one of the reasons why we have resistance. They use the drug is not working. And we can possibly tell you that in lineage, none of our products can you take into your laboratory for quality assurance process and you have anything less than 100%. None of our products. This has been done in several tertiary institutions. Just last week, we have several ones done in UCH in the back. Several has been done in Lagos, Lund, Nassau, and the likes. So we can assure you that our product has the recommended API percentage for you to have absolute results on your patients. So let me go back to the product I want to present properly. And yes, another point I want to make on this antimicrobial resistance is just about 3 weeks ago, the conference was held in Lagos by a group called Pharma. And they assert that only about 30% of Nigerians have access to quality drug. Meaning that 70% of Nigerians only have access to whatsoever they have. So it's a great concern that we all have a role to play. So that's the reason why we are coming here today to present our products to you so that you can take them into consideration. Yes. Next slide on the impact of antimicrobial resistance. Yes, if you look at the screen, you see that we highlighted about 8 of these bacteria that are common. And it can be seen here that the 22 common antibiotics that we use, and it's been shown that all these bacteria, they show resistance to them. These bacteria are very common, and the 22 common antibiotics that we use, these bacteria have shown resistance to them, which is a great concern. A patient that comes in for a very simple infection that is meant to be treated with the small antibiotics, you discover that after taking several months, it's not working, you have to go for the proper limit antibiotics. It's a great concern for us. So we all have a role to play on it. So now we are introducing our zero name, which is our meropenem brand. And this meropenem brand belongs to the carbapenem family, which are broad-spectrum antibiotics, and they tend to be more stable than other antibiotics. And of this family, we have the imipenem and we have the meropenem. So our zero name is of the meropenem family. Here in this presentation, I'll also try to highlight the difference between the meropenem family and the meropenem brand. Our own meropenem brand as against the imipenem because it's more stable and it's more of a professional antibiotics. So this is how our meropenem brand looks like. It's called zero name. It comes in powder form. It's a pale yellow powdered crystalline product where if you open it, just for you to authenticate the product, there is a scratch, there is a pin that you can scratch there. By the time you text the number, you are going to get feedback to confirm from the source that this product is actually from us. Is a means to like authenticate the product. Then once again, I want to assure you that any of our products that you are getting an authentic product. And we are looking at the fact that your institution might want to like do any quality assurance analysis on our products. We are here to give you samples for you to do that. And we can assure you that even if you go out to like get this product, you are still going to get the same result. Because some people can think because they know you want to carry out quality assurance and something on this product, that's the one you are giving us the authentic one. The one we give you, you can also as well go out and get another one. We can assure you that you are going to get the same result. Yes. So these are the common microbial spectrum of our antibiotics, which is meropenem, which is zero name of the meropenem brand. All these bacteria that you are looking at, the gram-positive errors, they are very, very sensitive to our meropenem. Starting from the Enterococcus faecalis, Staphylococcus aureus, the ones that are methicillin, it will clear every one of them. Then if you go to the gram-negative errors, all this, the zero name will clear every one of them. The next slide, if you go to the gram-positive anaerobes, all this in the gram-positive and gram-negative anaerobes, zero name clear every one of them. We can assure you that. Please go to the next slide. Yes. In this table, we just want to do a small comparison between zero name and the imipenem. If you use zero name in the presence of this enzyme, this renal dehydrogenase, zero name is going to be very, very stable as against imipenem that gets destroyed in the presence of this enzyme. So to achieve this result that your imipenem will not be destroyed, you have to combine with salicylate, which both of them they are kind of neurotoxic. So in this case, if you use zero name, it's going to be stable. It's not going to be destroyed at all. Then another difference between zero name and imipenem is if you have a patient that has meningitis and you use zero name, we can assure you that your patient is not going to like come down with seizure. But if you use imipenem, there is every likelihood that your patient comes down with seizure. So this is one of the reasons why you have zero name has a better edge over the imipenem family. And another fact is, as I mentioned earlier, if you use imipenem with salicylate, they are both neurotoxic, as against zero name that is not neurotoxic. Let's go to the next slide. I want to talk about the reconstitution of our zero name. Okay, let me talk about the dosage. Mostly in adults, the dose is between 500 milligram to 1 gram. You can see as that been highlighted here. But it's only in the case of bronchopulmonary infection and the acute bacterial meningitis that you have to double the dose. But every other case is between 500 milligram to 1 gram. As let me repeat the points, if you have a case of bronchopulmonary infection and acute bacterial meningitis, you just have to double the dose. Please show the next slide where we talk about the children. Yes, for the children, the same thing.
is between 10 to 20 milligram, but in the case of bronchial pulmonary infection and acute bacterial meningitis, you have to double the dose. Yes. Let's quickly go to the reconstitution slide. Our zero can be reconstituted in just 3 directives. The first one is the water for injection. If you reconstitute our zero with water for injection, you can leave it and you want to store it. You can leave it at room temperature, which is about 25 degrees Celsius. You can leave it for 3 hours. Then you can use it again. But if you have a case whereby you have to leave it for more than that period for you to reuse it, you can keep it inside the fridge and use it after 13 hours. Fridge, not the freezer part. Fridge. Then if you, because it's normal saline, you can use it within 1 hour at room temperature. But if you keep it inside the fridge, because you want to use it at a longer hour, then at that time you can use it after 15 hours. But if you reconstitute our zero with 5% dextrose, you have to use it today. Everybody knows that 5% dextrose is just like a medium bacterial dose, even from that dose. So that's the reason why you have to use it immediately. Please, let's do the next slide and talk about the cautionary note. Yes. These are cautionary notes for using the children. If you use it and you discover that the patient is showing some of the symptoms, skin rashes, alopecia, fever, and everything, we advise that you discontinue use it. And for the fact that all antibiotics have some kind of side effects, please go back to the last slide. Yes.
Change the pot.
Just like other normal antibiotics that the strong effect can wipe up the microphora. So you can notice some of these effects of the side effects of the patient. It's just normal. If you believe after the usage, your patient will become normal. Then most of the common questions about children is the effects of pregnancy. Yes, a study has been done that during animals, not yet on human beings. That's the reason why so, but most of the doctors that are using our products advise them that you only use children in place of pregnancy by the time you know that the advantage outweighs the risk for your patients. So that's the major point on the aspect of pregnancy. The study has been done on animal, but not yet on human. Then I want to conclude on children for this. As I mentioned before, they are highly broad-spectrum antibacterial, they are highly safe and effective, and I can assure you of the quality that is coming from building our results. I have to rush this because I have 3 other products that I need to showcase briefly. This is the only one I'm going to dwell on. These are our literature and this is our central brand. According to NAFDAC regulation, we separated them. We have the IV separately and we have the IV separately. The IV is the one called with the blue part, while the IM is the one called with the green part. The IV is called with 10 ml water for injection, while the IM is called with 3.5 ml lidocaine. Does it mean that we all know that central is highly painful by the time we use it by patient? So that's the reason why this IM is coming to 3.5 million local anesthesia, which is given to help more people. While the 10 water protection is the one that you can use. So as to avoid mistakes, that's the why we have to separate them. Although, according to what I said before, that a lot of companies, corporates in Nigeria, there are some centers that you still have where they have both the IM and the IM together. But we are adhering to the regulation of NAFDAC. So that's it. And we can assure you, as I said, our literature that in as much obviously we are cheating, it's sensitive to central. There is no other product that you use. There is no other product that you use whenever you that, okay, let me rephrase what I was saying. If they are using our cetrazole on any of the patients, we rest assured that if letrozole fails, even if you use roadshow, it's going to fail. It means that the only thing you're trying to treat is already resistant to cetrazole. So we can assure you, this letrozole is power equivalent to roadshow, and it's not in any way expensive as roadshow. It's not even close to it at all. So if you are using letrozole for your patient, you rest assured that in as much a patient is sensitive to the usage of letrozole, is going to cleanse. Then I want to quickly, I asked for the person of us to distribute our vitamin C for doctors to have a taste of it. We have our tube vitamin C 500 milligram. We all know that by the time you take all these tube vitamin C, there is aftertaste that you get at the end. Our company came up with this technology whereby if you take our vitamin C, there is no aftertaste. We can assure you that it's a secret of our business. We requested that everybody have a taste of it. And if you taste it, you will see that there is no aftertaste. Yes. So we are introducing that this items for immune boost for your patient, and after surgery, you can count on errors. That's our vitamin C. Then lastly, we have our azithromycin placebo. That's 100 milligram. We are the only company in Nigeria that has this innovation. Recently, we all know that NAFDAC banned all this anti-malaria that you have to reconstitute inside a container for the children. But because of the inability of them to be stable, for them to have not been stable, they banned it. So we came up with this strategy whereby we have a single dose unit for your patient. So if you want to treat your child with azithromycin 100 milligram, you just have to pick a unit of the sachet and dilute it inside water 5 minutes or 10 minutes and take it. The next day you want to do that, you do another one. The third day you do another one. So that's the uniqueness of this 100 milligram azithromycin. So those are the four products I want to showcase. Thank you very much.
Thank you so much for keeping to time and noting the signal. Please, do we have questions for you? Any questions? Any questions for you? Where?
Thank you very much. For now, we are still working with the hospital pharmacy probably they can allow us getting to this level. But for now, all our products are available with Sumter Pharmacy and Sabo. And also, they are available at the hospital pharmacy and we cannot ask you to do it. For the community pharmacy, all our products are available at Sumter Pharmacy. We are still working with the hospital to get them available. Okay, as for the meropenem that I mentioned earlier, the Zurine, that is 10,000 naira. Our entire cetrazole brand is 1,700 naira. And for the azithromycin 100 milligram, that one is 2,200 naira. While our vitamin C 500 milligram is also 2,200 naira. Thank you. The whole pack of the vitamin C 30,000 inside 2,200. It's 500 milligram.
Okay. Yes, ma'am. She has a question. Please don't hold it.
Thank you very much for the presentation. I have interest in that dispersible for azithromycin. Do you have that same formulation for antimalarials for children?
Yes, in 2 months' time, it will be. You are already working on it. In 2 months' time. I forgot to mention that our azithromycin is not flavored for the children. It's vanilla flavored so that they can use it.
Thank you for have it. Please, this last question of the entertainment. Last question of the entertainment, please.
Thank you so much for your presentation. Just out of curiosity, I wanted to know if these drugs have gone through clinical trials and what was the outcome?
Thank you very much. As I mentioned earlier, several trials have been done on our products. Not only on the 4 products I presented here, several of our products, trials have been done on them. And as I mentioned earlier, even presently now, we are working on collaboration at the Department of Surgery Institute on our American and our Central. So this is what we do almost regularly. That's the reason why I mentioned that even if the hospital here is willing to take our product for quality assurance analysis, we are ready to collaborate with them.
Alright, thank you so much, sir. Without further ado, permit me to invite for the vote of thanks the Chairman, Faculty Lecture Committee, Dr. Ogbomoso.
Good afternoon, everyone. Thank you very much for waiting till the end of this faculty lecture. I want to thank everyone because we transited from using your degree and for us all to come here. That means we are really in tune with what we do. I want to celebrate everyone. Thank you very much for being here. But more importantly, I want to thank God for the privilege to see this day and to make the program a success. And also want to thank the provost of College of Health Sciences, Professor O.T. Awotunde, and the Dean of Clinical Sciences, Professor A.Ido. Can we celebrate Professor A.Ido? He's such a great man. I don't know how I find myself here, but he knows how to get around things and get things. So he's a very great man. Thank you so much. And also want to thank several things that are here, things of nursing, physiotherapy, and every head of programs for being here. And also more importantly, I want to thank our professors. Professor Eshimo, thank you very much, sir. He and Professor Jill Adeniro, I wanted to use your verse to describe them, that through them grace and apostleship for obedience of Christ. It's through Professor Elisa and Professor Ola Adeniro that I'm able to stand before you. So thank you. Can you celebrate them? Also, we celebrate all our other professors, head of programs. Thank you very much. The CMP, PCS, Deputy CMAC, thank you very much. The other consultants, the senior fellow consultants, senior registrars, thank you, senior registrars, and our wonderful, excellent, and godly medical students. Nice celebrate us. And finally, our guest speaker. You know, he came in very shortly, but it was such a wonderful, just within the short period of time that he came, contributed so much immensely in the clinical, weekly clinical meeting that they have researching, and also to take that courage to present and be a blessing to the colleagues and then the hospital at that. I want to thank you so much. Thank you very much, sir. You're very wonderful. And don't let me forget, they are all my teachers in England because I graduated from England. Professor Abakuru, Professor Nduguba, and Professor Olaomi, thank you very much. Dr. Kwadu, thank you very much. I really appreciate it. Because I want to call this the Director of Nursing Services to me as one of the services.
Remains one person. For the professor.
I turn over this world to receive a wonderful thank you to what you have done and how you have taken control of this session of lecture. It's a video exalted Lord in Jesus' name. The session has been meaningful and impactful. I will pray that all that have been learned will be used effectively, even for the help of mankind in Jesus' name. Even for the lecturer, we pray that more of you and more of the divine wisdom and understanding will be released upon him. And as we all depart from here, we pray that we all depart from your presence. Be you how we move forward, be it as we move forward. And our students be graduated with excellency in Jesus' name. Thank you, Heavenly Father, in Jesus' name. Amen.
Thank you so much, ma'am. Please can we rise for the national anthem? Yes. We are in Nigeria. So we are tired of the Nigerians. The former president. The technical person. Should we wait for the sound of the program? Okay, can we go? The university anthem. Great institution, Bowen University, excellence and godliness is our extinct watchword. Though tongues may differ, in brotherhood we stand in Christ. Great institution, so thank you so much. See you at the next faculty